welcome everyone to our very exciting event this afternoon. My name is Basit Chaudhry. I'm an internal medicine physician and a researcher at the healthcare division of IBM. I'm also a co-chair of one of the Center for eHealth Information Technology at the PCPCC. I'm one of the co-chairs of the Task Force on Mobile Health, and I'd like to welcome everyone again. Our event today is entitled Innovation in the Medical Home, How Mobile and Social Technologies Can Accelerate Health Behavior Changes. We're very excited to have broad support for this event. It's co-sponsored by the PCPCC Center for eHealth Information Technology Adoption and Exchange, the Center for Consumer Engagement, the Center for eHealth's Mobile Task Force, and the Behavioral Health Task Force. So we have a really exciting array of people supporting and sponsoring and involved with the event. We're very happy to have everyone aboard for the webinar today. The PCPCC, just for people who aren't directly familiar with it, is one of the country's leading nonprofit organizations promoting the furtherment of primary care in the country, specifically supporting the patient-centered primary care medical home. It's done innovative, groundbreaking work on that. The Center for eHealth Information Technology is part of the PCPCC and focuses on promoting the adoption of information technology and how information technology can have transformative impact on how primary care is delivered in the U.S., specifically through medical homes. And it's also, I'd also just like to briefly mention the Mobile Task Force, which is again part of the Center for eHealth. We're focusing on looking on how mobile health technology in particular can have very exciting influences on how healthcare is delivered and how primary care is structured. So I'd also like to invite anyone who's particularly interested in mobile health to get in touch with me or one of the members of the PCPCC and get involved with the task force. Another announcement I'd just like to quickly make is we're very excited for the upcoming PCPCC stakeholders meeting, which is going to be held April 23rd and 24th in Washington, D.C. We've really expanded the programming this year and really filled out sort of a lot of the areas where we've heard people are interested in. We're looking for additional programming for the spring stakeholder meeting. So we expanded it to 2 days, and I think we have a very exciting forum planned for this spring. Just a few notes about the webinar itself. You can ask questions at any time during the talk. There's a question bar on the right of the webinar display, and you can just ask your questions through there. Questions will be read and held until the end of the presentation, when we'll have the Q&A portion of the session. The slides for today's talk will be available within 1 to 2 days through the PCPCC's website. You can just go to pcpcc.net /media, and the presentation will be there. And now it's my pleasure to introduce our featured speaker for today, Dr. Joseph Cavazo. Dr. Cavazo is lead for the Center for Global eHealth Innovation, a state-of-the-art research facility devoted to the evaluation and design of healthcare technology. It hosts 70 researchers and staff. Dr. Cavazo has been an active researcher on the use of technology to facilitate patient self-care for complex chronic diseases such as diabetes, end-stage renal disease, and congestive heart failure. He's also active in ethnographic research related to how new modes of patient care are mediated by technologies such as hospital at home and the personal health record. He's advised and conducted research for the public policy sector, policymakers in the private sector, including medical technology companies. His advice has touched on issues such as the design and safety of technologies in healthcare. He's the Senior Director of UHN Healthcare Human Factors, the largest group of its kind devoted to the application of human factors engineering, problems of healthcare delivery and patient safety. He is Assistant Professor in the Department of Health Policy, Management, and Evaluation, and the Institute of Biomaterials and Biomedical Engineering, Faculty of Medicine, University of Toronto. There he teaches and conducts research in areas of human factors, clinical engineering, and healthcare informatics. In 2010, he was the recipient of the Career Scientist Award by the Ontario Ministry of Health and Long-Term Care. It is my pleasure today to have Dr. Cavazo take us through this very exciting area of technology in primary care. Dr. Quazzo, over to you.
Thanks very much, Dr. Chaudhry. Hello, everyone. My pleasure to be here. I'm going to be covering over the next 35 to 45 minutes some of the work that we've been doing here at the Center for Global Health Innovation. We're based at the Toronto General Hospital right across the street from the University of Toronto. And together with my colleagues, we've done a number of technology development projects over the last few years, brought them through ideation, conception, prototyping, all the way through randomized control trials to test their efficacy. So I'm going to be covering sort of the gamut of this over a number of technologies that we've developed and trialed. So I want to start with, let me see if I can advance my first slide here, is that the focus of the talk will be in the area of chronic disease. So these are the big six, as we call them. And 60% of all chronic disease, of all spending in healthcare is actually on these six chronic conditions. And if you include all chronic conditions, it's as much as 80%. And this is not just Canadian statistics. It's the same as you would find in the U.S. and other developed countries. So, and really the purpose of our research, and the reason I'm a hospital-based research is that we were given the mandate nearly a decade ago, is in some sense to redefine the definition of a hospital. Because what I think some of our lead researchers here, some of our hospital administrators, our policymakers were realizing is that essentially the definition of a hospital has been virtually unchanged for the last 100 years. And given the prevalence of chronic disease now, is that hospitals are really only equipped to deal with acute events associated with chronic disease. And are we doing what we should be doing with respect to people who have chronic conditions? And we can treat the acute events associated with their disease very well. But is there some responsibility that we should be taking on dealing with patients in the community? And how can we be helping others, other care providers in the community, help those patients so that they avoid hospitalization? So this graphic here sort of represents our lifetime health trajectory. And what you see here is sort of the gamut of looking through someone's health status over time, through adolescence, through adult years, all the way to senior years. And you can see that on occasion we spike into these acute events associated with giving birth to a child, a car accident, heart attack, but these acute events happen more frequently as we age. And before you know it, we are into supported living, independent living. And we were looking at specifically these spikes late in life and whether or not we can actually avoid those spikes into the acute care space and avoid having these patients have these acute events, stay healthy at home, and hopefully remain independent. So, and that which is illustrated here. There's some obviously events in life that are unavoidable and that hopefully we can deal with. But again, those acute events later in life when people have multiple chronic conditions, those are the type of acute events we'd like to avoid. And here we are with this notion of how we spend our dollars. So an enormous amount of our healthcare dollar goes into this bottom right-hand quadrant where we have acute care, so ICUs, community hospitals, specialty clinics, and so on. And as depicted here, it's a very high cost of care per day, and the quality of life is relatively low. And what we are looking at in the definition of a hospital and a definition of how we should be spending our dollars is pushing a lot of what we could do within a hospital setting and pushing it into the upper left-hand quadrant where quality of life is better and the cost of care is lower. One of the first projects we undertook, which was a pretty high bar, was the notion of doing hemodialysis at home. So back at the beginning of the 2000s, this was quite novel, and in some respects, people thought that this was the craziest idea, is the idea of patients dialyzing at home. Obviously, peritoneal dialysis was well established, the other form of dialysis, but the home hemo was a very intense therapeutic process where patients would have to self-cannulate, operate a complex medical device in the home, And yet we do this now quite routinely. So many centers around the world are now considering the use of home hemo as an alternative to in-center hemodialysis. And the reasons for this are quite apparent. So the research that my colleagues have conducted over the last decade are becoming crystal clear. And there's a large randomized control trial by the NIH that is nearing completion that is showing some pretty remarkable improved health outcomes. And here's a list of some of the work that my colleagues and others have done in the areas of improved health outcomes for home hemodialysis. And beyond just the health outcomes, what's given to these patients is an improved autonomy, that no longer are they have to leave the workforce or leave school, and they can participate now because they have greater flexibility in doing their dialysis nocturnally, and that they're able to, again, go back to work, go back to school. And if that wasn't enough, it's in fact a much better cost-effective modality because of the elimination of the infrastructure that exists within hospitals and the high cost of nursing care. Patients are doing this on their own, and the nursing ratio is far lower than what would be in the hospital setting. And it's anywhere from 10 to 50% cheaper than delivering dialysis within the hospital. However, this is not a slam dunk. So the work that I did here back in 2004, 2005 was to try to find out what the barriers to home hemodialysis. So it is not a slam dunk. There is this perceived burden on family members of bringing such technology into the home. The fear of self-cannulation, right? So these are two very large cannulas that people have to administer themselves. And the fear of a catastrophic event in the absence of nursing support. So some of these patients have been in-center patients for a number of years, and the idea that they would have to deal with some events at home, quite frankly, it frightens them. And then just the general lack of self-efficacy that exists within the population, that whether or not they could actually do this. So, as one example of what we've done in terms of enabling patients to do this at home is create a remote patient monitoring system that we could observe patients in real time, them doing their dialysis. So we have electronic monitoring systems for the dialysis machine, so we know the status of the dialysis machine. We actually have, physiologically, we can see blood pressure values, we can see pulse oximetry values through a wireless Bluetooth oximeter. That's the Nonin sitting on the nightstand there. We've installed a call bell system, an IP call bell system, just as if they were an inpatient that they can press, and it immediately sends a message to the staff on call that evening, because most of these patients do this nocturnally. And we actually even developed a form of support that was one of the main concerns of some of these patients was exsanguination. So in case one of the cannulas become dislodged overnight and the pump continues to pump, this is one of their fears, is that they will lose massive amounts of blood. And so that pad that you see on the bed is actually a blood loss detection monitor, and it will immediately alert the care providers and stop the pump immediately if in fact it detects a loss of blood. So that is an example of an extreme form of remote patient monitoring. And what I'd like to talk now about is how we deal with chronic disease generally. This is a depiction of how the patient-provider feedback loop looks like within a family doctor's visit with a patient with chronic conditions. And typically what happens is data is gathered, it's interpreted by the family doctor, they act on the results, they communicate this back to the patient, and so goes the loop. Now, unfortunately, this only happens perhaps within a 10-minute period once every 3 months, and that's assuming the patient with hypertension or the patient with diabetes sees their doctor on a regular basis. But this is how the system is supposed to work. This is how chronic disease management is supposed to work in its simplest form. And it is what it's, the form of feedback is appropriate, but what if we could do this on a regular basis, even a daily basis, have this form of feedback? So which brings me to the notion of remote monitoring and self-care. So these are concepts that are not new. This was on the front page of the New York Times a few years ago, and this is a heart failure patient using a Honeywell HomeMed device, and sort of considered state-of-the-art back at that time. Still is a market leader, the Honeywell system, and you can see there that this patient is being prompted to put on a blood pressure monitor cuff, and I see a pulse oximeter there, and there's probably a number of peripherals that this device can support. The only issue with this is that many of the main purpose of these devices is primarily to get data from the patient to a physician so that they can make a decision. What we believe these systems lack is the ability for the patient to perform self-care, for them to be more self-aware of their condition, rather than the system just simply prompting them to take readings on a regular basis. So we really wanted to explore this more carefully, more thoughtfully, and whether or not this fellow, John Haydick of 86 years old, could actually be doing more personally for his care rather than just taking the readings themselves. So this is the Philips system, but again, the concept of remote patient monitoring and the feedback loop is pretty well established. So again, the number of medical peripherals, speaking to a base station electronically, that data goes through. There's a care manager there that alerts the care team to exceptions, and hopefully the physician follows up through a phone call and intervenes as necessary. The trouble with this model, however, is that the technology itself is very expensive. A system like this probably runs in the order of $5,000 with these number of peripherals, and that doesn't really include the cost of these professionals in the background here. That in some sense the workflow has been created around this technology, because there's typically not a care manager who's monitoring this data. Those are individuals who need to be put into place in order for this system to work. So it's fundamentally a shift in the care model, right? So that's why the uptake of this technology has not been universal. You hear a lot about pilots, you hear about the VA, but it's not in the mainstream. We don't do this typically with heart failure patients. It's still always the exception. The other issue is that we actually, in the end, have to prove that there is evidence to support the use of remote patient monitoring as an effective tool for chronic disease management. So there's lots of forces affecting the diffusion of health technologies. A lot of them are addressed, but the one that is also perhaps the most elusive is the evidence of effectiveness and cost effectiveness of the technology. Now, there have been a number of trials. One of the most notable ones is the SHEA study. Again, a VA-based study that showed a randomized control trial of type 2 diabetes patients. And what they showed, it was a very large trial, N of 844 in the intervention group, 1-year follow-up. And they followed a poor, underserved minority population. And they noted improvements in hemoglobin A1C, blood pressure, and lipids. Modest improvements, but improvements nonetheless. One of the biggest barriers they found, however, was, actually, before I go on to the limits of that study, there was another study published about 18 months ago in the New England Journal of Medicine that totally dismissed the use of remote patient monitoring. And their study concluded that there was no improved health outcomes in the use of remote patient monitoring for heart failure patients. And that was what they summarized. And this got lots of media attention, the notion that remote patient monitoring is in fact overhyped. And there's been a number of critics of this study, largely because the intervention was the telephone. So rather than the technology that I've been describing, what they defined remote patient monitoring was patients taking their measurements, calling up on an IVR system, and actually manually dialing in or through the touch tone system, entering in their blood pressure values, their weight, and so on. And their attrition rate was extremely high in this study, because this is probably the lowest common denominator in terms of remote patient monitoring system. And many people who are in the field of remote patient monitoring wouldn't even consider this to be that type of intervention. Yet it was labeled as such, and that's what got picked up in the media. If you look at the evidence more broadly beyond just the one New England Journal of Medicine study, if you look at the Cochrane collaboration study, they came up with different conclusions, that despite the fact that there was a wide variety in terms of the quality of the evaluation studies, they found that the structured telephone support and telemonitoring actually reduced the risk of all-cause mortality in heart failure patients. Which brings us back to SHEA. And again, one of the issues with SHEA is, in fact, the cost of the intervention. It's still quite costly to put these technologies into place. And the SHEA study pointed out just for the technology stuff was about $3,400 US per patient, which again, for diabetes, type 2 diabetes is excessive, because here in the province of Ontario, here in Canada, on average it costs about $5,500 a year to treat patients with type 2 diabetes. The cost of intervention of just the technology here is $3,400. So you can see that the case being made on something like this is not very compelling at this point. Spyglass, which is a consulting company, looked at this more closely on the business side, and really they felt that if remote patient monitoring was going to be ubiquitous, it was going to take hold, the cost of the systems had to drop from the orders of $3,000 to $5,000 to something like $300 to $500. So something on the consumer space. And they eventually saw the ability to buy these technologies in Walmart and Best Buy. And in fact, this study was done a number of years ago, and we're slowly starting to see actually some of these technologies become consumer-level technologies. So the notion of using a telephone is not, in fact, a bad one. But what we're arguing is that it is the smartphone which is the conduit of the future, with built-in intelligence, with built-in broadband internet connections, with the ability to message patients, to remind them, and to have intelligence built into the application, and also be able to communicate with medical devices. Which brought us to one of our first mobile phone-based remote patient monitoring projects. This is a system that we've developed here in Toronto, which again allows a mobile phone to communicate with medical device peripherals over Bluetooth with a very modest mobile phone. And in this case, it's a BlackBerry Pearl flip phone. And we used a number of these examples in different disease domains. Here's an example of a congestive heart failure client that was built specifically for the Pearl BlackBerry, which is able to acquire data from weight scales, blood pressure monitors, and even a single lead ECG. It also prompts the patient for symptoms and so on. And here are some just shots of the system as it would appear in the home with the Bluetooth-enabled blood pressure monitor and the Bluetooth-enabled ECG monitor. So again, blood pressure is possible, blood glucose is possible, single lead ECG. And our system in its first iteration used a rules-based engine to be able to, initially to be able to acquire data from a blood pressure monitor, a glucometer, transmit that over a mobile phone, and then the data would flow to our application servers. In our first instance, we targeted family physicians, and we had a server that only sent exceptions to the family doctor. We did not send every single data point to the physician. We knew that that would probably kill the adoption of the system. Really, family doctors are far too busy to monitor every single parameter that is sent to them. So the built-in intelligence, the rule set that we defined within the application servers, only sends exceptions to the physician. And interestingly enough, many family doctors, as people know, actually do not have an electronic means of actually receiving these clinical alerts. You know, the EHR adoption in Canada and the U.S. is still very low. It's growing, but still it's not ubiquitous. So the only way we could reliably alert these family doctors electronically was through the fax machine, and that's in fact what we did. We did not create a web portal because we knew that that was probably going to be problematic. Physicians would not log into those on a regular basis. The only way to do this was to use their existing workflow, and they get lab results and they get radiology reports all the time through fax machines, and we were just going to be another report that they would receive through the fax machine. We also included an adherence mechanism here because we knew historically that these remote patient monitoring systems had an attrition problem, a retention or an adherence issue that, over a period of 2 weeks, 4 weeks, 6 weeks, patients started dropping off The novelty of using remote patient monitoring had passed, and they had tucked their blood pressure monitor in a drawer, and they had forgotten about it. So our system monitors the data, and reminders are actually sent to the home phone, not the mobile phone, because the mobile phone may have already been turned off, but to the home phone to remind people that we have not received their data and to please continue to monitor their blood pressure or blood sugar depending on the patient. So that, in fact, was an annoyance for many patients, but in fact, it was, in the end, actually very effective in making sure that patients continue to use the system. So in the case of heart failure, what we did was monitor weight. This is a typical scenario of what a patient would do every morning before 10 a.m. So this is for the heart failure trial that we did recently. They would take their blood pressure measurements, and again, these are all Bluetooth-enabled devices. And for some patients, they would do single-lead ECG. And they would also answer this simple survey of about 10 questions of indicators that we would consider an indication of whether or not they are deteriorating or not. So this is just a couple of samples from the application here. And then the data would be automatically transferred back to our servers. And then the rule set would alert the care provider appropriately. And that could be someone on call, that could be the cardiologist, that could be a nurse practitioner. It depends on the way the clinic operates. So the patient reaction to the system during our randomized control trial was actually quite positive for the most part. They had a feeling of ease with the system. They felt like they were being watched and cared for. It was peace of mind for many of the patients. So the patient response was generally much more positive than in other groups, largely because these patients are sicker than most, and they appreciate the extra attention. Now, that's not enough to go on in terms of efficacy, because most patients in any form of telemedicine appreciate the use of these technologies. So, generally telemedicine interventions have patient satisfaction scores in the 90. So this was no different in this respect. From the clinician perspective, and this is Heather Ross, who was our clinical lead for the randomized control trial, she also felt that she herself was put at ease by knowing what the status of her patients are. She worries constantly about her heart failure patients after discharge, because what she cringes at is the hearing about them being admitted through the emergency department. And this was a way for her to be able to intervene earlier and prevent rehospitalization, and that was her intent. So for her personally, she wanted to continue to use the system even after the randomized control trial. So despite the fact that both patient and provider like the system, that's still not enough to go on. We have to go through the rigor of seeing if, in fact, there are improved health outcomes. So here is just a quick list of the type of evaluation studies that we've done. So we typically do pilots initially, and then we go based on the pilot data. If it's encouraging, if we learned anything from that, we iterate upon the technology, and then we go into a randomized control trial. So at first, I'd like to talk about our first RCT, which just finished up last summer and is about to be published any day now. So this is a randomized control trial of patients with diabetes, but we are actually tracking them for their comorbidity of hypertension. So what they would do is use this application on 3 times a week to take their blood pressure measurements, and this is what they would see on their screen. Now, blood sugar is also possible, but we did not monitor blood sugar in this particular trial. Graphs can be shown and so on. And this was the result of our hypertension pilot initially with just 30 patients. And you can see that using 2 forms of measurement, the 24-hour ambulatory blood pressure measurements and the 2-week average home blood pressure measurements, you can see a significant drop in both the systolic and diastolic blood pressure. So these were very encouraging results that have already been published in the American Journal of Hypertension. For our randomized control trial, we did something slightly different. We gave both groups of patients blood pressure monitors. The intervention group got a Bluetooth-enabled one, and the control group just got a conventional one, but otherwise they were the same. The intervention group also got the telemonitoring application running on the BlackBerry. And these were our results, very similar to the pilot. An improvement of 9.1 millimeters of mercury systolic, 3.2 millimeters of mercury in the intervention group, and there was no change in the control group. And this is a significant, both not only statistically but clinically. This is probably a reduction of 20 to 25% in terms of cardiovascular mortality. This was over a one-year period. This is sustained change. What else did we learn? Well, what was interesting about this particular pilot was that the physicians weren't responsible for the improvement. What we noticed is that there was no significant change in the management of the patient, no additional meds, and again, there was no significant changes in the management of the patient. What we found is that the mechanism appears to be patient self-awareness and the accountability to their family doctor. So the notion that they felt like they were being watched and that they became more self-aware over the course of the trial of their blood pressure caused them to adhere more and probably took their medications more frequently, and they would they would require fewer reminders to take their medication. So really that adherence mechanism is extremely important in these interventions. And the monitor, clearly, just giving them the blood pressure monitor is clearly not enough, because those in the control group got a blood pressure monitor and it had no effect over the course of 1 year. So looking at our heart failure trial, N of 100, 50 in the intervention group, 50 in the control group, a duration of 6 months. They were asked to take their daily measurements before 10 a.m. every morning. If we did not receive the readings at that time, they would automatically get a reminder call on their home phone number. And then the alerting algorithm that was developed messaged it directly to their cardiologist, and the control group was usual care. And this is what we found, is that in the intervention group, some of our key indicators of outcomes, BNP improved by 150 points, left ventricular ejection fraction improved by 7.4%, and the measures of self-care also improved by 7 points, and there was no change in the control group. So what we learned, and actually to go back, one of the health outcomes was rehospitalization, right? And unfortunately, we did not see an improvement in rehospitalization for those when comparing the two groups. And you know, we looked deep into the data as to why that was, and what we realized was that it was really a clinical workflow issue. Is that when the alerts did come through, rather than intervene in such a way that would prevent a rehospitalization, a lot of the clinical staff decided to ask the patient just to come in through emergency department to after hours when the clinic was not open in order to be seen. And again, that's sort of defeating the purpose of the system, but it just goes to show that it's not just about the technology, it's that in the background, the clinical system that's been put into place, the clinical personnel needs to be basically change their work practices to a certain extent in order to fully realize the potential of the remote monitoring system. So, you know, what we can conclude from this is that mHealth and RPM needs rigorous evidence-based design. Passive monitoring doesn't work, and active monitoring is required. And we believe that the future of mHealth is patient-focused, social, and consumer-initiated. What I want to go into now is the more mainstream mHealth work that we've done on the iPhone. We started off looking at this from the perspective of adolescents. Since the beginning, we've always been prompted, what are you doing about type 1 diabetes in adolescents, which is a very difficult population. So we decided to try a different platform. We decided to start developing on the iPhone instead of the BlackBerry for this particular project. By the time we started, we already realized that there were a number of diabetes apps already on the App Store. And what we found interesting is that many of them were just electronic versions of the paper logbooks that people already keep. And we actually didn't think that that was necessarily going to be particularly effective. And, you know, working with our colleagues across the street at the Hospital for Sick Children, we didn't really believe that a paper-based or an electronic logging book was going to improve patient self-care or their glycemic control. We endeavored to create a new application which we called BANT, with, again, working with the endocrinologist at Sick Kids and the type 1 diabetes clinic there. And right off the top, what we wanted to do was look at it, and the things that we wanted to try were, we wanted it to be mobile. We wanted to be able to encourage active self-monitoring on the adolescent's part. We wanted to provide the ability for teachable moments so that when they receive a reading that is an exception, that they know what to do about it. In fact, coach them through the process of interpreting that data. We also wanted a means to communicate between parents and providers electronically, create a community of engagement and adherence socially, and in fact, try the notion of rewarding them for positive health behaviors. So we use a user-centered design process here. Again, my background is in human factors engineering as well as biomedical engineering. So before we ever write a line of code, we spend a lot of time on design and conception, ideation. And so before we actually started building the application, we started drawing it. We started trying ideas out with adolescents, with parents, with endocrinologists before we wrote a single line of code. So version 1 was informed by a process which I can talk about here. One of the things that we knew was that the social community in diabetes is actually very active. And we noted that on Twitter in particular, we saw a very active community, and they self-identify themselves with the blue circle in their avatar. And they have these in a sense, these code hashes. So the hashtag BGNow represents blood glucose now, and these are people literally tweeting their blood sugar values. And it's a very large, very supportive community, and we wanted to tap into that. We felt it important, supportive, and generally a positive thing to try out with this population. So the first iteration of BANT was released in March of 2010. And it has a number of advanced features. It has full support of personal health records, initially Google Health, then Microsoft Health Vault. Google Health has been sunsetted now. It's no longer active, so we do still continue to support Microsoft Health Vault. It has the ability to tap into social networks. It does have a Twitter feed, diabetes-centric Twitter feed within the application, and it is also multilingual. And the multilingual aspect of it was a bit of an afterthought, but we have absolutely no regrets about it, and what we believe it to be is one of the main features of BANT is the fact that it now supports 11 languages, not 10. And we're really glad we did it for a number of reasons, which I'll get to. So over the course of the last 18 months, the app has been downloaded 42,000 times with really absolutely no promotion whatsoever. We're a public hospital. We have no budget for it. We barely had budget to build the application in the first place. And we're really impressed with the fact that this is an indication of the pent-up demand with patients with type 1 diabetes. It is a free application, so a lot of people probably tried it, and maybe even people who didn't have diabetes tried it. And we know that we have about 8,000 active daily users of the application worldwide. So they're, looking at the stats, it's been downloaded in over 76 countries. Perhaps not surprising, the United States is the most at 34.4%. But what was interesting is that you see Korea as number 2, and initially that surprised us, but it probably shouldn't have surprised us in showing you, how global the reach of this is that there really is no, at the time there was no Korean diabetes app on the App Store. This became the first Korean diabetes app. All the other apps were in English only. So Korea being a very wired country and the use of technology being very ubiquitous, it shouldn't surprise us that Korea was number 2. The other interesting areas, Italy, Brazil, a lot of the Spanish-speaking countries, lots of significant adoption despite limited penetration of the iPhone. The one that we've been noting most recently is that when we first started this project, China did not even register, and within the last few months we've seen a huge increase in the number of downloads from China as the iPhone starts penetrating that country, and the rising middle class of China starting to adopt this technology. So the clinical pilot was conducted at sick kids, and what we wanted to do with the clinical pilot to show the efficacy of this is simply try it on a limited population, 20 adolescents aged 12 to 16 with an uncontrolled hemoglobin A1C of between 8 and 10%. So these are patients who are having difficulty with their glycemic control. So we were deliberately trying to target individuals that were having difficulty, and the duration of the pilot was 3 months. And here's a few more details for the clinical pilot. What we were doing here was an advanced version of BANT. This is BANT version 2, which I'll get into how it differentiates. But our main outcome measure was to improve their average daily frequency of blood glucose measurement during the pilot compared to the 3 months prior. So we simply wanted them to test more often, because this is one of the biggest challenges of this age group, is they simply do not test their blood sugar regularly. So version 2. Through our user-centered design phase, we learned a few things through our interviews and our one-on-one discussions with both patients and their family caregivers, is that they felt that they wanted to become bigger decision makers in the process of managing their condition, rather than simply collecting data in the meter. That was something that they were seeking. They felt that there was really very little value in just collecting the data. They needed help interpreting and deciding what to do and act on that data. The other thing they said is that, especially when they're at school, they want this to be fast and discreet. They don't want to be messing around with a lot of technology. In many cases, they don't want people to know that they have diabetes, so they have to be in and out very easily with this application. The other thing is this notion of overcoming inertia, because they see the data coming in from their meter on a regular basis, but they wonder what to do about it, and they tend to wait until their next visit to act upon it. So this notion of clinical inertia that they have. And in the end, especially coming from the parents, is that they would like an ability to share this information, notably themselves, the parents themselves, but also a way of being able to easily share this data with their clinical care providers. So BANT version 2 is more advanced. It does have the ability to automatically read data from a glucometer. This is actually the first example of a glucometer wirelessly communicating with an iPhone. So this, again, went into a clinical trial earlier last spring, March through June. And these are just some screenshots of the process of being able to collect the data. Here's applying the droplet of blood, pulling the strip, BANT automatically starting up, an indication that there's data transfer between, the data transfer between the glucometer and the device, and an acknowledgement that the data was received. And there is an indication that the data was received, and you can see the various screens here of them contextualizing the data and also being able to go into the social network that's built within the application. So we started off with a wired version, and there's a number of wired glucometers now that are available on the market. IBG Star is one of them. But in the end, the kids really wanted a wireless one. They did not want to have a finicky thing where they had to connect a cable or connect the glucometer directly. They wanted it wirelessly. So we adapted OneTouch Ultra Mini and the Ultra so that it, through its serial port, would be able to transmit wirelessly. So it's all within their little pouch within their glucometer, and it wirelessly transfers. Again, some more screenshots of BANT. This is how it's indicated on the screen, again, in context. And again, it has the ability to identify trends. So 7-day, 14, 21-day trends. And you can see a number of statistics on how they're doing. And it also alerts. So this is the teachable moments aspect of it. It has the ability to detect that, in this particular case, this individual's had 6 low lunch readings through October 3rd through October 7th. And it prompts them, what will you do to stop this low trend from continuing? And in the end, the endocrinologist can look at their answers and be able to see whether or not this adolescent actually understands how to deal with their condition. Another example of an alerting trend here. As well, in our clinical trial, we had the data integrated with the personal health record. In this particular case, it's integrated with TELUS Health Space, which is essentially the Canadian version of Microsoft Health Vault. It is Microsoft Health Vault's product, but it has been localized to the Canadian market, and the exclusive distributor of it is TELUS, which is a telco here in Canada. Now, within the social community that was built into this, we actually did not use Twitter. We built our own microblogging server to be able for that the participants within the VANT trial were able to communicate with one another. So basically, this is a social community of only 20 kids. Yet it was very active during the course of the 3-month pilot. And what we actually found was very interesting is that they don't actually mention their condition very much. They don't talk about diabetes very often. They talk about their phones. They talk about apps. They talk about music, and so on. And in a sense, we don't actually care what they're talking about in the community, as long as the application is sticky and that they're continuing to come back and see what their peers are doing within the application, and they stay engaged. The last thing that we wanted to try was a rewards mechanism. So, we wanted to be able to reward them, perhaps not for the readings themselves, but just for the fact that they were taking regular blood sugar readings on a regular basis. So we had the ability to reward them with experience points for every reading they took. And these experience points could eventually accumulate and be redeemed for iTunes redemption codes. So in $99 and $2 increments, we would be able to give them the ability to buy music, to buy apps as a result of rewarding the positive health behavior of taking regular readings. And here's an example of what the reward screen is, and you can see that this person is accumulating experience points, and they're redeeming them on games like Angry Birds Rio or something else called Night Vision Picture and Video Spy Toolbox. Anything they want, really, that's available on the store. So we end up giving out hundreds of rewards, games, music, and we found it to be extremely effective in this population. So much so that within a very short period of time, the 3-month interval, we showed a 50% increase in the daily average frequency of blood glucose measurement. So on average, before the trial, they were measuring about 2.3 times a day. That improved to 3.5 measurements per day. So satisfaction was high within this group, as expected, 87.5%. Some of the difficulties that a few patients had is that they were used insulin pumps as well, which had an integrated meter, and it created workflow problems that they had in addition to their meter on the pump, which they preferred to use, that they had to use the secondary meter as well. So the workflow doesn't work for someone who has an integrated meter on their insulin pump. So this is something that we'd have to deal with in this particular use case. So the general comments were quite positive. It helped them think about their trends, what to do when alerts popped up. One child mentioned that they tested more often at lunch, which is always the one they tend to skip because they're at school at that time. And the rewards motivated them to test more. And one comment from one of the parents is that, which we felt was positive, is that she initiated more conversations about her blood sugars, which is always difficult in this adolescent group. So the whole notion of giving out iTunes redemption codes for the long term is probably not sustainable because who's going to be paying for these? So the use of iTunes is one thing. In the adult population, we're actually about to go into a pilot looking at using air miles as a reward instead of iTunes. But in the end, we don't actually believe that you need a tangible reward in order to elicit these positive health behaviors. That we know for a fact that there are literally tens of millions of people out there who go back to Farmville every day to harvest virtual artichokes. And it's, I can't explain it, but people do it. And it is very compelling to them. And we believe that we could create virtual rewards that are just as interesting for kids who have type 1 diabetes. So that is BANT. And a lot of people have asked us where we get the name BANT. And it is actually an acknowledgement of the heritage of the team here at Toronto General and the University of Toronto. It's a reference to Frederick Banting, who discovered insulin here at the University of Toronto. Actually, 90 years ago in January was the first test of insulin at Toronto General. So it's a recognition of the significance of that discovery even now, 90 years later. And just to note how significant the discovery of insulin was 90 years ago, this is a New Jersey-born Teddy Ryder who came up to Toronto in 1922 weighing a little less than 25 pounds here, near death, barely be able to stand, and who wanted to be treated by Frederick Banting. And a year later, in 1923, he wrote a letter to Dr. Banting wishing he could come see me. I'm a fat boy now, and I feel fine. And this is what he was referring to, just the miraculous recovery of the child due to insulin. So that's the reason we call it BANT, one of the most significant Canadian discoveries in medical science. And so again, I want to just conclude again on mHealth and RPM needs to be rigorous and evidence-based. Passive monitoring does not work. We believe active monitoring is required to elicit positive health behaviors. And we believe that the future of mHealth is patient-focused, social, and consumer-initiated. Thanks very much.
Thank you very much, Dr. Cafezzo. That was really a great overview and summary, much appreciated. And it really helped underscore the great promise of mobile and social technologies, how they can accelerate health behavior change, and how they might support the concept of PCMH. This is Dr. Warwick Charlton speaking, one of the co-chairs from the Center for Consumer Engagement. And just to remind attendees that if they would like to ask questions, you can pose them in the question box on the webinar tool. And if you do that, we'll endeavor to ask some of those questions for you of Dr. Cafezzo. So, Dr. Cafezzo, we've got a couple of questions that are pretty discrete, and I'll start with those, and then some more open-ended ones that follow.
Sure.
The first was you showed home hemodialysis results, and I think the time period was around 2003. There was an article you referenced. But can you update us on what home hemodialysis looks like now and what the adoption is, and have all the obstacles been kind of overcome, or is there still work to do?
Yeah, great question. So we have here at Toronto General about 100 patients now doing home hemodialysis. And it is the opinion of nephrologists that the upper limit of patients being able to do home hemodialysis is about 25% of the total population. And the reason being is that there is sort of a minimum cognitive behavioral aspect of the population that those criteria needs to be met in order for patients to be able to do home hemo. And also, I guess one of the biggest challenges is that the training currently is only available now in English. And like any major urban center in North America, we know that the dialysis community, in fact, is very diverse ethnically. And we really, if we're serious about home hemo, is that we have to be able to deliver the training materials in different languages, which is another limiting factor. And there's also, again, just a number of patients who just want to be cared for, and I think that's a valid concern as well, is that it is an enormous personal sacrifice for the patient and the family members to contemplate home hemodialysis. So, clinically, I think it's going to be clear that home hemodialysis will be, the efficacy of it will be shown both clinically and otherwise. but we probably will see an upper limit of about 25% of the total the total hemodialysis patients that can do that.
Great, thanks. That's helpful. Yeah, it sure seems like a more complicated chronic disease monitoring problem than some of the others that you touched on.
Absolutely.
The second question, a specific question, was you showed an interesting blood loss detector for that home hemodialysis service. And can you just discuss what it actually senses? Is it moisture or hemoglobin or
yeah, it's actually very simple. It actually monitors liquid. So within the pad is basically conductive strips of fabric, and it's a very simple device with respect to the fact that if it detects any form of liquid, that it will short out and signal. And we have had false positives in the past. So when using it, for one thing, one patient who dialyzed with their dog in bed, believe it or not, and the dog peed in the bed. So and that set off the alarm. So it's not a perfect system in that, and no, it does not detect hemoglobin. It's just a simple liquid monitor in that sense, almost like an anuresis monitor.
Okay. Actually, picking up the dog peeing in the bed sounds like a great use.
Yeah.
Okay. So going to some of the more open-ended questions, your focus was primarily on chronic condition monitoring, but is there a way to move further upstream, i.e. do more on the preventive side of mobile and social technologies as a way of affecting health behavior?
Mm-hmm. It's a good point. It's not something that we have been focused on, although we do have a number of researchers here that are looking at this a little bit more carefully, and they feel that they'd like to go into the health and wellness area and be more preventative. And there's certainly a number of not only researchers but companies now that have in a sense pivoted and started working in the areas of health and wellness. And if you looked at all the work that was coming out of the Consumer Electronics Show the last few weeks, many of the companies out there are working on prevention and health and wellness. It's not an area of work that we're doing. We're kind of focused in on because we're hospital-based. We're looking at our targets of the sickest of the sick patients, the patients who are regularly hospitalized. But you're right to say it is a huge area, and it's a fertile area for both research and business opportunities.
Okay, thanks. Can you talk a little bit about the reality that out there in the marketplace that many patients have multiple chronic conditions, mm-hmm. and yet want to have multiple apps to enter data into?
Yeah, it's an excellent point.
How to address that?
Yeah, and it's a great point. And I don't think we want patients to really fuss over every single parameter. And we contemplated that, in our first trial with diabetic hypertension, we had to make a determination of whether or not we wanted to have them monitor both blood pressure and monitor their blood sugar. And we came down to the conclusion that we actually were worried more about blood pressure than blood sugar. And this stuff does not come without a cost. One of the findings that we will be reporting for that particular randomized control trial is that despite the fact that the patients had an improvement in their hypertension control, is that on some scales they showed indications of anxiety and depression increased over the 1-year period. So, in some sense, we have to be very concerned about overloading these patients with worrying about too much. And we don't really have any regrets of not asking them to monitor their blood sugar as well. And so I think that's something that we have to investigate a little bit further as to what the cause of that was. But we do believe that there is a a consequence of self-awareness. So, previously these patients between visits probably, didn't think about their hypertension because, quite frankly, it's without symptoms. But now with the system, it's constantly reminding them to take their blood pressure. They're taking their blood pressure. They're taking their medication, and there is a mental cost to that. Something that we've been able to measure. So I'm not really for the idea of monitoring every single parameter. Perhaps the ones that are most problematic.
Yeah, that's a very interesting point about the impact of monitoring on patients, and obviously something that will have to be better understood.
Absolutely, yeah.
Sort of on the same subject, actually, is, you discussed some of the values of this kind of monitoring using mobile and social technologies on some of the parameters and values to the health system, such as total cost and improved healthcare parameters. But have you got any data or any opinion on what the most important direct benefits are to the patient? Why do they want to use it, or why do they use it, and why is it valuable to them?
I think it's different for different groups. I think for the heart failure patients, who are probably the sickest group that we're dealing with, it is peace of mind. They worry a lot in that particular disease group, and the idea that if they wake up and they take their measurements, and their cardiologist will be alerted if something is out of the ordinary, gives them a certain peace of mind. So I think for them, and actually, we don't talk enough about it, but for the family caregiver associated with that patient, in that respect, it's probably peace of mind, because heart failure is something that is quite obvious to a person on a daily basis, right? It's limiting their activities and so on. They're probably more self-aware than the person with diabetic hypertension. With the kids, the adolescents, clearly I think there was a certain motivation just for getting the iPhone, right? We had very little trouble recruiting in that pilot. Is that everybody heard about the pilot that included the iPhone, but beyond that, we knew that wasn't going to last long in the long term. So we needed an adherence mechanism there as well, and we tried out the social networking and we tried the rewards mechanism. To me, it's still unclear whether or not the social networking would be enough. I think there's a certain subgroup within that group of 20 that really enjoyed it. We don't know whether or not it would have been enough. We actually believe that the gamification aspect of rewarding, creating a game out of the notion of taking your measurements on a regular basis and getting, multipliers for consecutive measurements, and then winning an award, a tangible award, was the primary mechanism for those kids.
Yeah, that was very interesting. Just to remind attendees again, if they'd like to have a question posed, please post it on the webinar question board. Thanks. So now, your pilot, and you mentioned that you posted the online app for the band app free. Have you thought, as you sort of go forward and as your user base grows, what the sort of ongoing support costs are going to be like, and have you thought through how you would monetize that, and basically how you'd approach supporting something like that over the longer term?
Yeah, I don't think there is, and we've discussed this at length, and I've sort of warned a lot of startup companies who are considering this space as well, is that, it's easy for me as an academic to create these applications. I only have to worry about the grant that started initiated this. I have other grants that can, we update the app on probably 3 or 4 times a year. But to create a business model out of this is quite difficult. Even if we had charged $5 for band, let's say, that would have brought in $200,000 of revenue. And I can tell you right now, it costs more than $200,000 to develop and build that app because it required, designers, human factors professionals, graduate students, and the developers themselves. And that was not including all the free time that, our endocrinologists, our clinical staff, and so on contributed to it as well. And the willingness to pay for this stuff needs to be tested, but in particular in Canada, we know it to be low. There's an expectation in Canada that healthcare services are provided, and I'm not sure it's that much different in the U.S. I don't know how much people would be willing to pay for this sort of thing. And in the end, you have to also look at the total population. Yes, diabetes is highly prevalent. There's probably 30 million people in the U.S. with type 2 diabetes, but the number that has type 1 diabetes probably is in the $1 to $2 million range. You have to think about the number of those who have a smartphone and then the ones who are willing to pay for an app for it. So, it's difficult to create a business model out of it, and in the end, there may not be one. And it may be just an ecospace of free and open source apps that exist through and are supported by public institutions.
That's a great point, and one of the big barriers to development and adoption of these. I think another one is that when you have only partial penetration in a population, then your clinical staff have essentially, or let's say you have multiple systems, then your clinical staff have sort of multiple inputs that they have to monitor. And so if there's not really a standard around them,
yeah, you're absolutely right.
Easy way to do that, it's quite complicated.
Yeah, you're absolutely right, yeah.
Okay, you talked quite a bit about some of the factors that help with encourage patient participation in your younger diabetic group. But can you talk a little bit about what some other factors or what you feel are key factors for patient participation and active self-monitoring? Anything that you hadn't touched on or that you're looking at now?
Well, to a certain extent with any trial, even a randomized control trial, there is a certain level of self-selection in here. So, these patients had to agree to have been put into this trial, and even those who were randomized into the intervention group knew that there was that risk that they could have been in the control group and not receive anything, right? So, I think the main issue is that we have learned something different from each group. The heart failure group was different than the diabetic hypertension group. That was certainly different than the adolescent type 1 group. There's one other group that I didn't mention. We have just finished a randomized control trial on diabetes during pregnancy. So these are type 1s, type 2s, and gestational diabetes patients who are in their last trimester of their, and so that is, again, another unique group because as you sort of pointed out, is that the motivations and the reasons why they're doing it and are different in each group. And it's sort of the level of the level of the chronic condition. So those who are heart failure patients are highly motivated. I can tell you that the patients in the diabetes during pregnancy are highly motivated and highly adherent because they're in a high risk. There's a lot riding on their behavior. But those who have type 2 diabetes and hypertension, again, they may or may not have any symptoms at all. And certainly the adolescent group, the tactics that are being used now to try to get these kids to, practice better self-care behaviors don't work, right? So the notion of telling them that, if you're not careful, you'll go into end-stage renal disease by the time you're 40. Well, telling someone who's 14 that they're going to have, a critical chronic condition and be on dialysis at age 40 does not have an effect. You might as well say that'll happen when you're 100. It doesn't mean much. So, what we have learned is that these interventions are quite tailored to these different groups. Like the tactics that we have used for behavior change has been modified in almost every trial that we've done. Now, it's not to say that BANT in its present form couldn't apply to the type 2 population, because the notion of rewards, I think, would work just as well in the adult population. And the notion of casual gaming and the concepts of gamification, I think, would probably work as well on BANT for type 2 patients. But we haven't tried it yet. So lots more research to be done on that.
Great, thanks. That's a nice comprehensive answer. One of the webinar attendees asked if you've come across anything on weight loss using this kind of technology that you feel is heading in the right direction or had an experience with.
We haven't done anything specifically on weight loss. Our systems do support the weight scale, and there are a number of already commercial devices out there, support systems like the WeThings. The French company WeThings has produced a Wi-Fi scale with accompanying software and so on that will tweak your weight, and in some sense, I'm not sure how many people are willing to do that, but again, the scale will automatically connect to your Twitter account and tweet your weight, and maybe that's one way of self-motivating. I don't think there's been any trials on demonstrating the efficacy of that. I think it's grounded in something in terms of the social aspect of that. So some of this is being played out already in the consumer space. And again, at the last Consumer Electronics Show was probably the most active in health products. So a number of weight scales, blood pressure monitors, glucometers, complete systems were being demonstrated at the Consumer Electronics Show. So a lot of these companies are releasing products in advance of any evidence to support them, and I think that's fine. And in some sense, hopefully there's an opportunity to be able to collect data and show some efficacy in that respect.
Great. A couple of questions about BANT, more about how you envision it going forward, and what are your plans, I guess, would be the summary question.
So BANT is right now, obviously the version that's available in the App Store right now is freely available, but it is the limited version. It does not have the device connectivity. It does not have the advanced features, and that is largely the reason we haven't released that version is largely due to the regulatory issue that surrounds it. So because it connects to a medical device, the app itself becomes a medical device as well. For the purpose of the pilot, we received from Health Canada an investigational test authorization to use it in a limited clinical trial. That's the equivalent of an IDE in the United States, an investigational device exemption. But in order for it to go into the mainstream, we have to bring it through the regulatory process. And we are actually in the process of going through what is known as there's a quality management system called ISO 1345, which we need to be compliant with and then apply for the license. And we hope that by year end, the application and its support of other glucometers is possible. So, will it be compatible with other glucometers? There is already the IBG Star glucometer that has been approved by the FDA, but is not on the market quite yet. There's the potential to support that, and maybe other glucometers. But slowly, the medical device manufacturers are coming around to the notion of creating Bluetooth-enabled medical devices. It is slow, but it is happening, and we hope that we'd be supporting more glucometers and getting it and get through the regulatory process in 2012.
Great. So I'm expecting that until that time, primary care physicians who might be interested in BANT right now can't really recommend it to their patients or can't really use it until that process is is advanced, or is that not?
Only within a clinical trial. So if there's some interest in creating a clinical trial, that is doable, because it's a you would be enrolling patients. Either Health Canada or the FDA would be informed of that, and so within the context of a clinical trial, it can, but not general use. Now, people are free to use the free version, and again, it supports Microsoft Health Falls, and but it does not have the advanced features. All the data entry is manual. It does not have the teachable moments. It does not have the alerting mechanism, because again, if you alert a patient, if it detects a trend and alerts the patient, that is a clinical intervention, and you have crossed the line into a regulated system. So we have to be cognizant of those things.
Okay, perfect. It seems like there are lots of pilots like this working with mobile and social technologies and so on. Are you aware of any one place that sort of describes what those trials or pilots are around the country, that people can see what activities are going on, or is there a resource like that that you found useful?
Well, there are a number of mHealth related news sources that a lot of the listeners probably already frequent. I think one of the best ones is Mobi Health News, which you're probably familiar with. Yes, they cover mostly the business aspects, but on occasion they do talk about the science and the clinical trials around this. So Brian Dolan, who is the editor of Mobi Health News, I think does a pretty good job at being able to curate all the activity that is happening in the mHealth space. And he has a colleague, Neil Versel, who also writes. And again, they're mostly focused in on a lot of the startups and the business aspects in mHealth, but they are cognizant of the fact that in healthcare, it's not enough to just create products. There has to be some evidence to support it. There is the regulatory issues, so they write frequently on some of the clinical trials as well that are occurring. So I would recommend that as a news source.
Great. There's a question about the fact that you showed a number of measures about how some of these technologies have actually helped improve things like frequency of blood glucose readings and stuff. I'm imagining that you don't have much in the way of outcomes per se, just because of the length of time required and then sort of.
Yeah, that's a good question. That's a good question. Yeah. So the real hard one is the diabetic hypertension one. Is the primary outcome being improved hypertension control. We did show a significant clinical improvement on that one. With the BANT trial, yes, it's very difficult to show an improvement in hemoglobin A1C in only 3 months with only 20 kids. So our objective for the pilot was to show that there was an improvement in the frequency of daily blood sugar measurements. And there have been studies that have shown that in fact, that an improvement in frequency of blood sugar measurement actually can create an improvement in hemoglobin A1C in the long term. So our RCT, which we're in the planning stages for, our primary outcome for that trial will be improved A1C. But there's no way we could have shown that given our limited sample and the limited scope time-wise of the trial currently.
Perfect. And you're not really aware of other outcomes-based studies using mHealth that listeners could read?
Yeah, well, there was in the type 2 population, there was a study that was recently completed, and they showed an improvement in hemoglobin A1C of 1.9%, which is a huge difference. And that, this particular company, and for some reason their name escapes me, and I saw them at the mHealth Summit in Washington. They're an interesting company because, yes, they are creating a commercial product, but they have been doing this very hard legwork of showing evidence as well. And again, I'm just trying to remember their name. I've blanked on their name. I'm not sure why, but I've discussed this with their with the team there quite frequently. But again, there is a study that came out in Diabetes Care that it was a 1-year randomized control trial with type 2 patients. And again, they showed an improvement of A1C of 1.9%.
Thank you. There are a couple of questions about the social community that you set up. I think you mentioned that you don't actively, you don't really care what people write on that. It's just more a communication mechanism. A couple of comments have been, well, does that need to be monitored to sort of prevent inappropriate behavior? Mm-hmm. And secondly, monitored in case people are giving bad advice on how to manage your blood sugar control, and is that an issue that you need to address?
Yeah. So for the public version uses Twitter, and obviously we're not monitoring it, and nor can we control what's going on in Twitter. We feel that on balance, there's more positive that will come out within the diabetes community, and I've been probably following the diabetes community online on Twitter for the last 2 or 3 years, and I've never seen anything even remotely controversial in that space. Within the private microblogging environment within BANT, yes, we were monitoring the kids. They knew that we were monitoring them, and we did not see anything inappropriate. The risk obviously is there. But you have to make it a judgment at some point whether or not, on balance, it's a positive thing or a negative thing. And in some respects, because they knew that we were monitoring them, we knew that some of their discourse was targeted us, right? At one point, they were openly discussing, whether or not the person who had the highest score during the pilot should win the iPhone, right, or win an iPad, right? So they were cognizant of the fact that they were being monitored in that respect. But I think, it's our opinion that on balance, the positive aspects outweigh the potential negative aspects.
Great. One of the questions is about, you talked about feedback from the care team and from the users themselves, but did you get feedback from their family members at all about any perceived improvements or changes that they saw in patients using these systems?
Yeah, so again, different for different groups, but I think in particular for the heart failure patients, and in particular for the home hemodialysis patients, their family caregivers are ecstatic about remote patient monitoring. They probably have a greater desire for remote patient monitoring than any other group because they live with a lot of stress dealing with a loved one who has a serious chronic condition. With the parents of the type 1 diabetes patients, some of it is a bit of relief, and they're supportive of the use of it because it's in some sense a way of making the whole issue of monitoring and self-management a little less confrontational, and they appreciated that. In some circles, the child was a little bit more communicative about their condition than they would have been normally. And maybe that's still just a novelty thing, and over the long term that would subside. The parents also have the ability through the HealthVault account to actually see the blood sugars. And that's not, that's not actually necessarily easy to do otherwise without BANT, because the parent would have to ask the child for the meter. There's usually some argument over that, largely because the adolescent probably knows that they haven't been taking the readings and doesn't want to show that. But with this was pretty transparent. Every reading that the child was taking was populating the HealthVault account, and the parent could go in and monitor and see what those readings were like.
Perfect. Well, Dr. Cafaza, we've come to the end of a great session. There were a number of comments about how well your talk was received. Thank you very much for your time and the great preparation. And thank you also to the Centers for eHealth Information Adoption and Exchange and the Center for Consumer Engagement and the Behavioral Health Task Force for sponsoring this webinar today. And with that, we'll close the webinar. Thanks everyone for your attendance today and the great questions.
Thank you.
Thank you.